The premium plans of 12 months. So premium plan includes some services like pre-recorded class, live doubt clarification, one-to-one personalized guidance, notes, quick revision, examination module. And this premium plan costs around 50,000, and also for instant 20% discount, you can use my code Aanchal20. So these are the questions to be covered in today's class. That is mechanism of urine formation, maturation reflex, RAS, phosphate buffer in kidney abnormalities, maturation, then dialysis and renal circulation. These are the important topics that we're going to discuss in today's class. So let's proceed with today's first topic, that is RAS. So RAS stands for renin-angiotensin system. So as yesterday we have discussed that glomerular apparatus are the structures that are responsible for secreting renin, right? So when renin is released into the blood, it contains a specific protein called angiotensin. Okay, so renin is responsible for secreting angiotensin. Or renin substrate. Okay. Now, it is the alpha-2 globulin, and by the action of renin, the angiotensin is converted into decapeptide. Okay, so that is known as angiotensin 1. As we can see in the diagram, this is known as decapeptide, and this angiotensin 1 also converted into angiotensin 2, and this is known as octapeptide. Okay. Now, by the activity of enzyme that is known as ACE. ACE is the enzyme known as angiotensin converting enzyme, and this is called secreted from lungs. Okay. Now, most of the conversion of angiotensin 1 into angiotensin 2 take place inside lungs. Okay. Now, angiotensin 2 has a short lifespan of about 1 to 2 minutes. Then it is rapidly degraded into heptapeptide, which is known as angiotensin 3. Okay. So, this angiotensin 2 converted into angiotensin 3. Okay. Fine. Now, this angiotensin 3 is also converted by using an enzyme which is secreted or which is present in RBC. So that enzyme is known as angiotensinase. Okay, that are present in RBC and vascular beds in many tissue. Okay, now this angiotensin 3 is converted into angiotensin 4, and this is a hexapeptide, right? Now, one by one, we're going to understand the action of various enzymes that we have discussed. Okay, so angiotensin 1 is physically inactive. This is always physically inactive, and it serves as a precursor for angiotensin 2. Whereas this angiotensin 2 is present in the very active form, and the various action it perform, like it performed on blood vessels, adrenal cortex, then on kidney also, on brain also. So one by one, we're going to discuss about the action of angiotensin. Okay. So on blood vessel, this angiotensin 2 is responsible for increasing arterial blood pressure by directly acting on the blood vessels, and also it is responsible for causing vasoconstriction. Okay, so it is a potent constriction of arteriole, and earlier when its action were not found, it was known as hypertensive. Right now, it is also responsible for increasing the blood pressure indirectly by increasing the release of noradrenaline from ganglionic sympathetic fibers, and noradrenaline is a general vasoconstriction. Then if we talk about the action of angiotensin 2 on adrenal cortex, so it stimulates zona glomerulosa of adrenal cortex to secrete a very important enzyme, that is aldosterone. And aldosterone act on renal tubule, and also this is responsible for increasing the retention of sodium, which is responsible for elevation of blood pressure. Right. Then third, if we talk about the action of angiotensin on kidney, so here angiotensin 2 regulates GFR, and in two ways it regulates GFR. The first, by constriction of the afferent arteriole, in which there will be decrease in filtration rate, and second, it also responsible for the contraction of glomerular mesangial cells, which leads to decrease in surface area of glomerular capillary and filtration. Okay. Then if we talk about the action of angiotensin on brain, so in angiotensin also responsible for inhibiting the baroreceptor reflex and thereby directly increases the blood pressure, and baroreceptor reflex is responsible for decreasing blood pressure. It also increases water intake by stimulating the thrust center. Okay. Now, if we talk about the action of angiotensin 3, so this is also responsible for increasing blood pressure, and this is also responsible for stimulating aldosterone secretion from adrenal cortex. Okay. Now, if we talk about the action of angiotensin 4, so it has a adrenocorticostimulating and vasopressin activities. Okay. So if we look for the RAS system again, so angiotensinogen is responsible for conversion of into angiotensin with the help of the enzyme renin that got released from JJ apparatus. Then this got converted into angiotensin 2 with the help of ACE that is released from lungs. Then angiotensin 3 that occurs with the help of enzyme angiotensinase. Then 4. Okay. Then finally, they all are responsible for increasing aldosterone secretion and causing vasoconstriction. Okay. And if we talk about the action of angiotensin 2, so it is responsible for the regulation of GFR, increasing BP, increasing water intake, increasing ADH secretion. Okay, so this is all about RAS system. Now next we have renal circulation. So if we talk about renal circulation, so in renal circulation, we talk about the various arteries that are present, right? So in renal circulation, we have the starting from aorta to renal artery, then from renal artery to segmental artery, then blood will flow from segmental to interlobular artery, then arcuate artery, interlobular artery, afferent arteriole, and finally glomerular. So this is the entry pathway. And if we look for the exit pathway, so from glomerulus, the exit will occur from afferent arteriole, then afferent arteriole from capillary, peritubular capillary, and then from peritubular capillary, vasa recta is also there associated with it, then interlobular vein, then arcuate vein, interlobar vein, and renal vein, and finally from inferior vena cava back to heart. Okay. So if we talk about renal circulation, so blood vessels of kidney are very highly specialized to facilitate the function of nephron in the formation of urine, right? In adults, during resting condition, both the kidney receive around 1300 ml of blood per minute. Okay, and that is of about 26% of cardiac output. Okay, so maximum blood supply to kidney has got the functional significance, and renal artery supply to the kidney. Okay, so this is all about the renal circulation. Now next we have the mechanism of urine formation, and this is considered to be the most important question, and usually the questions asked in the university exam. So we're going to discuss the various steps. Already the first step we have covered in yesterday class, that was glomerular filtration. Okay, so urine formation is the blood cleansing action of kidney, right? Through which the blood could get purified. Okay, so normally around 1300 ml of blood enters the kidney, and kidney excretes the unwanted substances along with water from the blood as urine. Okay, so normal urinary output is 1 to 1.5 liter per day. Okay, but if we look for the GFR, means the total amount of blood is coming, so 180 liter per day, and we have only 1 to 1.5 liter, means 99% of water get reabsorbed back, and only 1% from the urine. Okay, so we have three steps. First is glomerular filtration, then tubular reabsorption and secretion. So one by one, we're going to discuss about all these steps. Okay, so when blood passes through the glomerulus, okay, we have glomerulus. Okay, so when blood passes through the glomerulus, the plasma is filtered into the Bowman's capsule like this, and this process is known as the first step, that is glomerular filtration. Okay, now the filtrate from the Bowman's capsule passes through the tubular portion of nephron. While passing through the tubule, the filtrate undergo various changes both in quality and quantity, and many unwanted substances like glucose, amino acids, water, electrolytes are reabsorbed from the tubule, and this process is known as tubular reabsorption. Okay, then if we talk about the tubular secretion, so some unwanted substances that get secreted into the tubular from peritubular blood vessels, so that process is known as tubular secretion or excretion. Okay, now as we have discussed that three steps are there: glomerular filtration, tubular reabsorption and secretion. So now we're going to discuss these steps in detail. So as we have already covered the glomerular filtration, so when water and solutes small than protein are forced into the through the capillary wall and pores of the glomerulus capsule into the renal tubule. So this glomerular filtration is the process by which the blood is filtered while passing through the glomerular capillary by filtration membrane, and this is the first step of urine formation, and the structure of filtration is suited for the this process. Okay, now, next we have the another one, that is tubular reabsorption, and already we have covered the first step, so we're not going to discuss it in detail, but tubular reabsorption, we're going to understand a little bit in detail, okay? So, if we talk about tubular reabsorption, so tubular reabsorption, as we have discussed, this is the process by which water and electrolyte and other substances are transported from renal tubule back to the blood. Okay, substances transported. Right? Now, when the glomerular filtrate flows through the tubular portion of nephron, both quantitative and qualitative changes will occur, and large quantity of water, more than 90% of electrolytes and other substances are reabsorbed by the tubular epithelial cells, and the reabsorbed substances move into the interstitial of renal medulla, and from here the substances move into the blood in peritubular capillaries. Okay, since the substances are taken back into the blood from glomerular filtrate, the entire process is known as tubular reabsorption. Okay, now various things are there that get reabsorbed, so that mechanism also we're going to discuss in detail. So if we talk about the mechanism of reabsorption, so we have two. First is active, second is passive. Okay, so active reabsorption is the movement of molecules against the electrochemical gradient, right? And if we talk about the passive process, so here, this is the movement of molecules along the concentration gradient or electrochemical gradient. Okay, then if we talk about the routes of absorption, so in routes we have transcellular and paracellular. Okay, then in transcellular the substances move through the cell, and it includes transport of substances from tubular lumen into tubular cell through apical surface of the cell and tubular cell into interstitial fluid and interstitial fluid into capillary. Whereas in paracellular route, substances move through the intercellular space, and it includes the transport of the substances from tubular lumen into interstitial fluid present in lateral intercellular space through the tight junction between the cells, right? Now, next we're going to discuss about the sites of reabsorption. So in sites, we have PCT, then we have loop of Henle, and then we have DCT and CT, collecting duct. Okay. So when we talk about the substances reabsorbed from PCT, so about 7 by 8 of the filtrate, means about 88% of filtrate get reabsorbed from PCT. Here, the blush water type of epithelium is present in PCT, which increases the surface area, and also it increases the facilitation for the process of reabsorption. Okay. So what are the substances that get reabsorbed? Many substances are there like glucose, sodium, amino acids, potassium, calcium, bicarbonate, many other substances are there. Okay. Then if we look for the loop of Henle, so in loop of Henle, two types are there. First, we have this ascending limb and descending limb. So ascending limb is permeable for water. Uh, Ascending limb is permeable for electrolytes and impermeable for water. And whereas the descending limb is permeable for water and impermeable for electrolytes. So this is how the reabsorption will occur. Then next we have this DCT. So from DCT, again, sodium, calcium, chloride, bicarbonate, and water get reabsorbed. Here also water get reabsorbed. Okay. Then finally from collecting tubules, so substances reabsorbed in collecting duct are again sodium, but sodium occurs in the presence of hormone, that is aldosterone. And water will be absorbed in the presence of hormone, that is ADH. And along with this, urea get reabsorbed. Okay, so this is all about the process of tubular reabsorption that is occurs in the different segment of the nephron. Right. Finally, have the last step, that is the secretion. Okay, so if we talk about the tubular secretion, so tubular secretion is the process by which the substances are transported from blood to renal tubules. Okay. So it is also known as the tubular excretion, and in addition to reabsorption from renal tubules, substances are also secreted into lumen from the peritubular capillaries through tubular epithelial cells. Okay. And substances like PAH, that is para-aminohydrochloric acid, then amino derivatives, then penicillin. Okay. Now, another thing that some substances also there that is secreted in different segment of renal tubule, that also we're going to discuss. Like first we have ammonia, that is get secreted into PCT. Then we have hydrogen ion, that is get secreted in PCT and also in DCT. And also maximum hydrogen ion secretion occurs in PCT. Then urea is there, that gets secreted in loop of Henle, and potassium we have that actively secreted by sodium potassium pump in PCT, DCT, and collecting tube. Okay, so these are the different segments that got secreted in renal tubule. Okay, different part. Then we have the phosphate buffer system inside kidney. So when we talk about the tubular cell, so here carbon dioxide combines with water to form as we can see, to form carbonic acid. In the presence of enzyme, that is known as carbonic anhydride. And as we know, this is a very unstable product. So it get dissociate immediately into water and bicarbonate. Right now, what will happen next? Now, as it get dissociate from the this bicarbonate from the tubular cells enters the interstitium. Okay, so it is present in interstitium, and also sodium get reabsorbed from renal tubule under the influence of hormone, that is aldosterone. As we can see, the reabsorption is occurring. Then this Na will enter into the interstitium, as we can see. Okay, so it enters the interstitium and combines with bicarbonate. Okay, so here they will form sodium bicarbonate, right? Now, the hydrogen ion which is secreted into the renal tubule react with phosphate buffer, and it combined with sodium, and finally it forms sodium hydrogen phosphate. Okay, so sodium hydrogen phosphate is excreted in urine, and the hydrogen ion which is added to urine in the form of sodium dihydrogen makes the urine slightly acidic, and it happens mainly in VCT and collecting duct because of the presence of large quantity of sodium hydrogen phosphate in these segments. Okay, so this is all about the phosphate buffer system. Now next we have the very another important topic, that is maturation reflex. So what is maturation? Maturation is a process by which the urine gets voided. From urinary bladder, right? And it is a reflex process, and in grown-up children and adults, it can be controlled voluntary by some extent, right? So if we talk about the process, so for process, we should know the some anatomy of this bladder. Okay, so if we look at the structure of bladder, so this urinary bladder is a triangular hollow structure located in lower abdomen. Okay, and it has a body part and it has a neck part right here. So all of the urinary bladder are formed from smooth muscles. Okay, and it contains detrusor muscles. So these muscles are known as detrusor muscles. Okay, and also at the posterior surface of the bladder, there is a formation of trigone, and this trigone triangle-like structure is known as trigone. And at the upper angle of the trigone, two ureter can enter like this, and they always present like this oblique. Okay, so they are also associated with kidney, as the kidney will form the urine, so directly the ureter will transfer that urine into the bladder. Okay, so now urethra we have here, and here we have two sphincter. The inner one is known as internal sphincter, and the outer one is known as external sphincter. Right, now we're going to learn about the process of this maturation. Okay, so what happened in this process? Basically, this is the reflex by which maturation occur. Okay, and this reflex is elicited by the stimulation of stretch receptors. So in the wall of this urinary bladder, some receptors are present, and those receptors are known as stretch receptors. Okay, now this reflex is initiated by the stimulation of stretch receptors on the wall of urinary bladder and also in urethra. So what happened when about 300 to 400 ml of urine get collected inside the bladder, then there will be rise in the intervesicular pressure. Intervesicular pressure is there. Okay, and this stretches the wall of the bladder, that result in the stretch of receptors that are present in the bladder, and stimulation of stretch receptors will occur, and there will be generation of impulses, and those impulses will pass through a very important nerve, and that is known as pelvic nerve. Okay, so pelvic nerve will send the signal to the sacral segment of spinal cord, and as the sacral they have S2, S3 and S4. So as the sacral segment of spinal cord will receive the signal, again they will send signal through afferent impulses, again through pelvic nerve, and there will be contraction of this bladder. So as they will be, like, this is a balloon, okay? So as there will be contraction in the muscle will occur, so that will push the urine into the urethra. Okay, so contraction of detrusor muscles and relaxation of internal sphincter, there will be flow of urine into urethra. So there will be flow of urine into urethra, and also stretch receptors are present that get stimulated, and then efferent impulses will be there through pelvic nerve, and there will be innervation of pudendal nerve. So as the pudendal nerve get innervated, there will be relaxation of external sphincter, and it leads to voiding. Okay, so this is how the entire process will work in maturation. Another thing we have to learn about the function and nerve supply. Okay, so when we talk about the sympathetic and parasympathetic and somatic. So sympathetic we have, parasympathetic we have, and somatic. So we're going to learn their action on detrusor muscle, internal sphincter, external sphincter. Okay, so whenever sympathetic nerve are there, the action will be there on detrusor muscle. So it will cause the relaxation of detrusor muscle. As the detrusor muscle they relax, they will be cause the constriction of internal sphincter. Internal constriction means close. It will remain close and not supplied. Sympathetic nerve not supply external sphincter. Okay. Then role of parasympathetic. So they will be responsible for the contraction of detrusor muscle. There will be opening of internal sphincter by relaxation, and again it not get supplied by parasympathetic. This external sphincter is only supplied by somatic. That's why it will always remain voluntary. So whenever this somatic nerve will supply this external sphincter, it will cause its constriction. Means if this system is active, the external sphincter will always remain closed, and as it get inhibited, it will leads to relaxation of external sphincter, and it will open it. Okay, and here it not supplied and not supplied. Okay, so this is about the nerve supply, nerve function of nerve supplying urinary bladder and sphincter. Fine. Then another thing we have is the abnormalities that is present of maturation, right? So when we talk about the different abnormalities, so in abnormalities, we first have the atonic bladder. So in atonic bladder, this is the urinary bladder with loss of tone. In the detrusor muscle. And this is also known as flaccid and neurogenic bladder and hyperactive neurogenic bladder. And it is caused by the destruction of sensory nerve fibers. Okay, so there will be destruction of sensory nerve fibers. So due to the destruction of sensory nerve fibers, the bladder is filled without any stretch signal to spinal cord. And due to absence of stretch signals, the detrusor muscles will lose the tone and become flaccid, so that the bladder is completely filled with urine and without any maturation. And now these urine outflows in drops as when it entered the bladder. And this outflow incontinence, or known as incontinence, or overflow dripping. Okay, and where various causes are there of this atonic bladder. The causes includes spinal injury, then we have the condition like syphilis. Okay, so if we talk about spinal injury, so spinal injury, it's the first stage of this atonic. Basically, this is the first stage of spinal shock. Okay, after injury to sacral segment of spinal cord in the bladder, which become atonic. Okay, now in case of syphilis, So syphilis results in the degeneration of nervous disorder, and that nervous disorder is known as TAPes dorsalis. Okay, which is characterized by the degeneration of dorsal nerve root, and degeneration of dorsal nerve root of sacral region develop atonic bladder, and the atonic bladder in TAPes dorsalis is known as tabatic bladder also. The next we have this automatic bladder. So automatic bladder is the urinary bladder characterized by hyperactive maturation. So here the maturation process will be too hyperactive. Okay, and there will be loss of voluntary control. So even a small amount of urine get collected inside the bladder, that will also elicit the reflex that causing emptying of bladder, and this occurs during the second stage after the complete transection of spinal cord above the sacral segment. Okay, then we have uninhibited neurogenic bladder. So this is the urinary bladder with frequent and uncontrollable maturation. Caused by lesion in midbrain, and this is also known as spastic neurogenic bladder or hyperactive neurogenic bladder. Then we have nocturnal maturation. Nocturnal maturation means involuntary voiding of urine, and it occurs in night time. That's why it is named as nocturnal. Okay, so it is otherwise known as nocturnal enuresis and also bedwetting. So because bedwetting is due to nocturnal voiding of urine, and it occurs due to absence of voluntary control. Here voluntary control will be lost, and it is a very common and nocturnal process that occurs in children, in infants also, and it is because of incomplete myelination of motor nerve fibers of the bladder, and when myelination is completed, voluntary control of maturation get developed, and also bedwetting will get stops. Okay. Now, next we have the very important topic, that is dialysis. So what is dialysis? So as the name refers, dialysis. Dialysis is the process to remove waste and toxic substances from body fluids. Okay. So it is also known as hemodialysis, because in this case we do the purification of blood. Okay. So this machine we can see in the picture, it is an artificial machine that is used to carry dialysis during renal failure. Okay, so usually this occurs in renal failure when kidney loses ability to purify the blood. At that time it is used to carry. Okay, so mechanism, if you look at the mechanism of function of artificial kidney, so dialysis refers to the diffusion of solutes from an area of high concentration to low concentration through a semi-permeable membrane. Okay, so this forms the principle of artificial kidney, and patient's arterial blood is passed continuously or intermittently through the artificial kidney and brought back to the blood through vein. And here there is an anticoagulant. So anticoagulant we use the uh, again, the very natural one. So anticoagulant is heparin that we used. So inside artificial kidney, the blood passes through the dialysis, and that is known as hemofilter. This is the hemofilter we have, which contain minute channels interposed between two cell phone membrane, and the cell phone membrane are porous in nature, and the outer surface of these membrane is bathed in the dialysing fluid, and we are having this dialysis solution, which is also known as dialysate. Okay. Then, if we talk about the frequency and duration, so the frequency and duration of dialysis depend upon the severity of renal dysfunction, and dialysis is usually done thrice a week in the case of severe uremia. Means uremia is the condition in which majorly there is accumulation of urea. Okay. Then another thing we have is peritoneal dialysis. So if we talk about peritoneal dialysis, so this is the technique in which peritoneal membrane uses as a semi-permeable membrane. And here it is also used to treat the patient who is suffering from the renal dysfunction or renal failure. So what we do in this process, again, a catheter is inserted into the peritoneal cavity through the anterior abdominal wall and it gets sutured. Right now, the dialysing solution will get passed through the catheter under gravity, and the required electrolyte and also dialysate pass through vascular peritoneum into blood vessels abdominal cavity. And here also like substances like urea, creatinine, phosphate, and many other unwanted substances get diffused from the blood vessels into dialysate, and later dialysate is drained from peritoneal cavity by gravity. Okay, so what are the advantages of this peritoneal process, dialysis? So if you look at the advantages, so this is very simple, convenient, and less expensive process. So that's why it is preferred more. Okay. So compared to the hemodialysis, this has become more easier. Okay. And also patient can prevent themselves patient can themselves change the fluid on an outpatient basis. So it has few drawback also. It is less efficient in removing many toxic substances, and also it can lead to the chances of infection. Okay. Then if we talk about the complication of dialysis, so many complications are there, like sleep disorder. The person can have anxiety, depression. Okay. So this is all about the process of depression. And I think we have covered all the important topics of today's class, starting from mechanism of urine formation, maturation, RAS, phosphate buffer, abnormality of maturation, dialysis, and renal circulation. So I hope you find this class helpful. So thank you so much for watching my class. Thank you.